If your SOAP notes are getting flagged in audits, causing authorization delays, or just not holding up under review, the problem usually isn't your clinical knowledge, it's your documentation structure. And in this video, we're going to fix that. By the end of this video, you're going to know exactly what goes in every section of a SOAP note, why most clinicians get the assessment section wrong, how to write a plan that actually creates accountability, and the most common documentation mistakes that create compliance exposure for you and your organization. What is a SOAP note and why the format exists? So the SOAP stands for Subjective, Objective, Assessment, and Plan. It was developed by Dr. Lawrence Weed in the 1960s as part of a broader movement to make clinical records more organized, problem focused, and defensible. Decades later, it's still the gold standard, and for good reason. The SOAP format works because it mirrors how clinicians actually think. You gather what the patient tells you, you observe what you can measure, you analyze what it means, then you decide what to do next. 4 steps in order every time. Think about what happens when that structure breaks down. A case manager documents their clinical opinions inside the objective section, or they list a new diagnosis in the assessment without any corresponding action in the plan. A reviewer, whether that's a supervisor, a payer, or a compliance officer, picks up that note and immediately loses confidence in the documentation. That note becomes a liability instead of an asset. Before you write your next note, ask yourself one question. Does every sentence in each section belong only in that section? That single discipline check will catch the majority of structural errors before they ever become a problem. Here's a number worth sitting with. Poor clinical documentation costs US healthcare organizations an estimated 8.3 billion US dollars annually in rework compliance failures and care coordination breakdowns. A well-structured SOAP note isn't just good practice, it's financial protection for your organization. The subjective section belongs entirely to the patient's voice. Chief compliant, history of present illness, relevant past medical, social, and family history, any changes since the last encounter. All of it filtered through what the patient reports, not what you think about what they report. Here's what this looks like in practice. If your patient tells you their plan is a 7 out of 10 and started after lifting something heavy last week, that language goes into S, exactly as stated, or paraphrased without editing. The moment you write, patient appears to be exaggerating pain response in the subjective section, you've crossed a line. That interpretation belongs in assessment. For case managers specifically, the subjective section is also where you capture functional status, self-reported barriers to care, and support system information. These aren't soft observations. They're clinical inputs that directly shape your care plan. A simple rule, if you couldn't have known it without the patient telling you, it goes in S. If you can measure it, observe it, or verify it independently, it goes somewhere else. Ask yourself this. When was the last time you reviewed your own subjective sections and found clinician interpretation buried in them? It happens more than most teams realize, and it's one of the first things auditors look for. The objective section. Objective data is anything measurable, observable, or independently verifiable. Vital signs, lab values, diagnostic results, functional assessment scores, like a CATS ADL score, behavioral observations you made directly during the encounter, third-party reports from other providers with source and date noted. If a physical therapist's notes document that your patient is ambulating 50 feet independently, that belongs in O. but you cite the PT note, the date, and who authored it, you're not guessing, you're referencing a verified source. Here's where teams most often go wrong in the objective section. They include unverified patient statements. If the patient tells you they've been taking their medication as prescribed, that is a subjective report. It goes in S. The objective section is reserved for what you can confirm. Now, before finalizing your O section, run every data point through one filter. Can I independently verify this? If yes, it belongs in O. If no, it belongs in S, with the patient as the attributed source. The assessment section. This is the section most clinicians underwrite, and the one that matters most during audits and utilization reviews. The assessment is not a restatement of your diagnosis. It is your clinical synthesis. You're connecting what a patient reported to what you measured and arriving at a professional judgment about their current status, their trajectory, and their response to interventions. Now, here's what a weak assessment looks like. Patient has type 2 diabetes and hypertension. That's a diagnosis list. It tells the reviewer nothing about the clinical reasoning. A strong assessment looks like this. Patient's HbA1c has increased from 6.8 to 8.2 since last encounter despite reported medication adherence. Suggests potential dietary non-compliance or medication efficacy issue. Patient verbalized motivation to encourage with dietitian. Moderate risk for near-term hospitalization if glycemic control is not improved. See the difference? The second version shows reasoning. It explains why this patient and this moment warrants specific action. For every active issue in your assessment, ask 3 questions. What is the current status? What is driving that status? What is the risk if we don't act? If your assessment answers all 3, it will hold up under any review. Picture this. An authorization reviewer receives 30 case management notes to evaluate in a single afternoon. They spend an average of 90 seconds per note. Your assessment section is the single biggest factor in whether they approve or deny. That 90 seconds is worth protecting. The plan section should be specific enough that a colleague who has never met your patient could execute it without calling you. Every action item needs 3 things. Who is responsible? When will it happen? And why? A brief clinical rationale that ties the action back to your assessment. Compare these 2 plan entries. First, follow up as needed. Or the second one, referral placed as registered dietitian. Target appointment within 14 days to address glycemic control barrier identified in assessment. Case manager to confirm appointment scheduling by next encounter on date. The first creates an accountability gap. The second creates a workflow. Only one of them belongs in a compliant, high-quality clinical record. Review your last 5 plan sections. Count how many action items have a named responsible party, a time frame, and a clinical rationale. That number tells you exactly where your documentation stands and exactly what to fix. Now that we've covered the SOAP structure itself, let's talk briefly about when SOAP is the right choice and when it isn't. DAP notes, or Data Assessment Plan, combine the subjective and objective into a single data section. They're common in behavioral health settings where the SO distinction is harder to maintain. BURP notes, Behavior Intervention Response Plan, are often used in mental health therapy. They focus on what the clinician did and how the patient responded. SOAP remains the most defensible format for medical and multidisciplinary care coordination settings. It has the clearest payer recognition, the strongest alignment with billing documentation requirements, and the most explicit separation of patient-reported versus clinician-verified information. If your organization is evaluating documentation formats, SOAP is the standard to anchor to, with format variations adapted to your specific care setting. All right, let's recap and bring this together. Here are 5 things you can apply to your documentation starting today. 1. Keep subjective and objective rigorously separated. Patient reports go in S, independently verified data goes in O. No crossover. 2. Write your assessment as clinical synthesis, not as diagnosis list. Show your reasoning, document status, drivers, and risk. 3. Make every plan item specific, owner, time frame, rationale. If it doesn't have all 3, it's not a plan, it's a placeholder. 4. Review your notes before finalizing them. Ask, does every sentence belong in this section where it's placed? 5. Recognize that documentation quality is a team-wide issue, not just an individual skill. Inconsistent note quality across a team compounds into audit risk, authorization delays, and care coordination failures that affect patient outcomes. Strong SOAP documentation is one of the most leverageable skills in case management. It protects your patients, your organization, and your professional record every single encounter. Ready to fix your team's documentation? If your team is still relying on inconsistent templates or free text documentation that doesn't enforce SOAP structure, then that's a solvable problem. Case Management Hub is built then for you. With guided SOAP note templates, team-wide note templates, advanced note tracking capabilities, and account-wide note permissions, you can ensure that you and your team follow the best practices in ensuring strong SOAP documentation. If you want to experience these great features and more, below this video is a link to start a free trial of Case Management Hub. This gives you and members of your team the opportunity to explore the platform, evaluate it, and to see if it's the best fit for your organizational needs. Once you click the link, you'll be brought to this page. Just enter your first name, last name, and email, as well as your organization name, and select your practice area. We also recommend that you enter a phone number. Once you're done, you'll be brought to the main dashboard, which allows you to perform quick actions among many other things. Let's take a look at how you can easily create a SOAP note in Case Management Hub. Step 1, we're going to navigate to the Notes module from the sidebar. And then we're going to click Add Note. Step 2, from the Note Type dropdown, select SOAP Note Template. Step 3, add your note details to the 4 sections of the SOAP note, select the client, and then click Save. Step 4, you can view, search, and filter all of your client notes, including the SOAP notes, in one place. Step 5, click the eye icon to view or edit the details of the note. And don't forget to like this video, as it lets me know that you've received value from it. You can also subscribe to the channel so you don't miss great content like this one.